everybody, welcome to another episode of Bullhorns and Sirens. Sorry it's been a while, we've all been rather busy with our personal lives. It's myself and...
Tommy, I thought you forgot my name there.
I didn't forget your name. I'm not looking at you to introduce yourself. Hosting today, unfortunately James can't be with us. He is on his advanced Crayola course, I believe.
Yeah, he's learning the blue crayon this week.
Very exciting for him. Don't the Heart team get up to all sorts of amazing things?
They do. But today we've got a really special guest on, haven't we, Sam?
We have. We are very, very excited to share our guest with you today, who is just one of the most amazing midwives you will ever get the chance to listen to, meet. And if you ever see her running a CPD session, whether it's free or not, just jump on it. It's going to be the most life-changing maternity session you do.
There we go. So yeah, that was I actually wrote out an introduction.
Oh, did you? Oh, sorry. Right, Tommy, go over your introduction.
So we've got Dawn. She's a consultant midwife, and we're very lucky to have her on the podcast today. So she's only one of 3 consultant midwives in the whole of the UK, believe it or not. And she's got experience in the field of A&E nursing and midwifery, and now she works for an ambulance service as a consultant midwife. So please give a big welcome to the mic. It's Dawn Kerslake.
I mean, how do you follow that? I'm so embarrassed. Well, thank you for having me. Should be my starter for 10, shouldn't it? Yeah, you're right. I have had a nice, rich and varied career.
Yeah.
Do you want me to tell you a little bit about what I've done?
Yeah, absolutely.
Oh gosh, I'm going to give my age away. So 32 years I've worked for the NHS, and I started as a nurse, and I worked in ED in London. And then I had a really bad Christmas in A&E, and decided I didn't want to be a nurse anymore and I might go and do something else. And midwifery sounded quite appealing. Yeah, it was going to be a happy job, all right? So tore out the page on babies and off I went to St George's and trained to be a midwife. And I've been doing that for, 25 years now, and I love it. And I think my husband would say that I am married to the NHS and probably moreover the ambulance service now. So it's really different, it's really interesting. I've done all areas of midwifery, and I finally ended up as a labour ward midwife and then the matron of labour ward in a London hospital. And then this job came up and it sounded really interesting. And obviously I have a bit of a passion for emergency medicine. So it sounded like my kind of thing. And I think when about 6 colleagues emailed it to me, that kind of made me go, probably should apply.
Either that or they didn't want to work for you anymore.
It might have been that. It might have been that. You should definitely get your coat and apply for this job. So yeah, that's why I'm here.
It was a sign.
And that was 5 years ago.
Oh, wow. So not really that long ago when you think about it in the grand scheme of things. It's like a whole new career. So that bad Christmas that you had in ED, it was that pushed you, I'm not doing nursing anymore.
It was the final nail in the coffin. Yeah, it was. I won't go into the details, but I did a pretty horrible job on Christmas Day. Yeah. And as a result of that, I reflected and thought, do I really want to carry on doing this? And you both know, emergency medicine, there's no thanks ever, is there? And I think I was a bit fed up and beaten with constantly being flogged, and it was always bad, and people are always screaming at you and shouting at you because they've got to wait and they don't want to. And I thought midwifery sounded really lovely. I mean, I've reflected on that since.
Did it meet your expectations?
Well, it did. I think as a junior midwife, I loved it, and I trained in the days when there was less litigation, and it was a little easier. I think it's really hard now, and I think the new students coming through have really got their work cut out. But I still love it, and in actual fact, the things that scared me when I was first qualified are the things that interest me most now, and they're the things that I surround myself with. So that tends to be the trauma of the emergency care in maternity.
Oh, that's awesome. So then is the love for emergency medicine, obviously that's the reason why you went to the ED nursing. Is that what then brought you into the ambulance service then?
Probably, but a lot later. I mean, if you think about midwifery in terms of the acute side of it, I guess labour ward is where the acute side is and the high-risk women are. So yeah, I always leant more towards that. I did my stint in community, I did my stint in the birth centre, and I always thought, I just want to go and work on labour ward again. That's where my passion is. So yeah, I always wanted to get back to it.
Oh, okay. And then so your role in the ambulance service as a consultant midwife, what kind of things do you do sort of on a day-to-day basis?
Okay, so I get asked this quite a lot, and in actual fact, midwives often ask if they can come and shadow me for the day, and the poor things would be so bored. So a lot of what I do is really quite dull. The stuff I love doing, and the biggest part of my job, is training. Now, if I'm honest, my other consultant midwife colleague in the Northwest does more of the guidelines, risk, etc. She does much less training, but she's got a brain the size of a planet, so she's much better at all of that. Whereas I focus a lot more on the training element. Oh, and she's got a team as well. She's managed to build a team, which has been brilliant. So you can, where I'm going with that is you can kind of create the job however you want it to be. The ambulance trust that I work at, there was quite a need for training, and the medical director when I joined asked me to focus on that. So that's the biggest part of my job, and there's all sorts of different ways that I'm delivering that. I've also now got involved with JR Calc, our ambulance service guidance, for those midwives listening that might not know what that is. And the ambulance service does have its own guidelines. So like you do in a hospital, we have our own as well, and they're very different to what we would do in a hospital. So that's been a huge chunk when I joined, and I was quite fortunate when I joined that I was asked to look after some senior clinicians, what we call our CCPs, and it's probably fair to say when I joined I thought I had the answers, and it very quickly became apparent to me that I did not.
And sorry, CCPs, they're paramedics with a specialty in critical care.
Yes, that's correct.
Yeah.
So they go to the more trauma and sort of cardiac arrest, higher acuity jobs. So thank you. Yes, I always forget my acronyms should be thought out.
No, that's all right.
So I worked with them really closely, and I think collectively we came up with something quite meaningful.
Yeah.
And so I hope now we've managed to write some guidance, both internally within our ambulance service and also nationally, that is a bit more meaningful to pre-hospital clinicians.
That's pretty good. So I think it's awesome. So the other consultant midwives that work in other ambulance services, you almost integrate your strengths to make it better for everyone, kind of thing.
I think so, yeah. So my colleague in NWAS is much more of an academic. So, and she loves research. So that is very much her focus, and she's brilliant at it. But, and she's much more strategic than me. I hate to say it, but she really is. I probably am much more of a clinician. I like to be doing. So we play to each other's strengths really well, I hope. I think she would agree. But yeah, we share the work out across all the ambulance services that have got midwives. And we've got a leads group now in all the trusts.
Yeah,
Oh, that's really cool.
That's awesome.
Yeah, I didn't know that. I thought it would just be like, keep the trust separate, don't
Yeah,
they? Like,
same,
is what
yeah.
you normally expect. But it's good that we're talking to each other, because it means we're going to have that set sort of standard across the board, no matter what trust you walk into.
We share everything. So we have a network and a group. We have a WhatsApp group as well across all the ambulance services in the UK. In fact, this weekend, one of the midwives in Wales has been asking for things, and if we've already done it, let's just share it. Put your logo on the top. Use it.
Yeah. Do you use the guidelines? What guidelines do you guys use in midwifery? Is it like NICE guidelines, or do you have your own separate sort of stuff? And how much does that portray and drag over into the ambulance service?
Okay, so in a hospital we refer to NICE and RCOG, which is Royal College of Obstetrics and Gynecology, and probably we lean more to the latter, if I'm honest. And the guidelines in hospital are written collectively with the training midwives and the obstetricians, so they all have a bit of an input. Whereas pre-hospitally, I think historically they were written by a predecessor of mine who was the consultant midwife at LES for a long time. But like all things, evidence changes, guidance changes, so we have to update them regularly. But we're trying to do it as a collective, so we're trying to do it so that all of the ambulance services are having an input into a different guideline, so that we all get to do one or t'other. And we're about to lead on some videos. They're going to be silent videos so that you could watch them on a job. So say you needed to know how to get a breech baby out, and it's all well and good writing an algorithm, but sometimes a picture or a video speaks 1,000 words, doesn't it?
Yeah,
so
100%.
we're making them silent so that you could go in the corner of a room and you could just quickly watch where you needed to put your hands to assist that baby to birth. So that's the aim. They're not made yet, but we're making them at the moment.
That's good, yeah.
Yeah. Are they like videos of actual people, or are they like animated type stuff? Or?
No, so they're us, as in the midwives, the collective of us that are
Yeah.
making them. So we will be real, but
Okay.
we'll be using a mannequin.
Oh, that's cool.
That's good. At least then you can say, whilst you're dealing with the mum, you can go off to your crewmate and say, look, can you just watch this? And then what we're going to do is swap. I'm going to then watch it. And watch it. That's it. That's it. And then like whilst you can get halfway through doing the resuscitarium, you know what they say when you get on scene to a maternity job, always get the resuscitarium out just in case. Whilst you're doing that, watch the video as well. That's pretty cool.
There's one other thing which is quite exciting actually, which I thought I might mention, is at the moment the NLS algorithm is written for hospital-based clinicians.
Yeah.
And there's a few of us collectively, in fact it's led by a fantastic neonatologist in Bristol, have got together and we have decided that we are going to make a pre-hospital NLS course.
Oh, that'd be awesome.
So I won't name drop everybody, but some people that you guys will definitely know have helped and assisted with running this course. So we've already delivered a proof of concept course, or a pilot, I can't remember which way round it was, in Exeter, and we're about to do the next course somewhere. It's not actually been decided yet where, but it's going to be somewhere in the UK, and then that will be a bona fide NLS pre-hospital NLS course that we'll all be delivering on, which is so much better for our pre-hospital.
It would be good because I find the NLS algorithm it's so like it's like there's so many things to remember, isn't there? And then you have to do your ventilations, and then you have to listen, and then you do enough more and there's so many things that can go wrong in that algorithm.
Everything's 30 seconds, Tommy. Everything. Yeah. If you don't know the answer, it's 30.
Yeah, that's it. Yeah.
Except not the heart rate. Not the heart rate. The heart rate should. That would be bad if the heart rate's 30. Let me just be clear.
If everything's 30, then it's fine.
Yeah. But it's true that, and unfortunately, like because of how busy we are, like as a service and as services pre-hospital, we don't get enough time other than maybe one session a year to revisit and review all those sort of guidelines and practice that sort of thing, unless you're in like a specialist, like the crit care sort of role. And so when you do turn up to that, it's quite sort of horrifying in a sense, isn't it? Because you're sort of like, God, I've got to really throw back to the last time we did this and practice this. And you can read as much as you want on the way to the job, but once you're faced with it, it's completely different.
Yeah, it is. That's it. Yeah, and you have all these things in your mind about what it could be, and then when you get there, it's completely different.
We have done internally a really nice soundbite for those people that work in maybe the southeast of the UK. They have a soundbite on their JR Calc, which is specific to that trust.
Yeah.
It's 2 minutes 40 seconds of me talking you through NLS, which you could listen to on your way to a job.
Yeah.
So I will eventually share that with all the other trusts, because it would just be so much easier, wouldn't it, if you were on your way to a job just to hit play and then the dulcet tones of Dawn Kerslake going, when you arrive on scene.
I mean, we've got Bluetooth in the ambulances. We'll get you on like the speaker into the back of the vehicle.
Conference me in as well. That's also a thing that I might be able to do.
Give the iPad to the dad and say, right, just press play in 2 seconds.
Just setting up.
Yeah.
No, don't worry what for. You'll see.
So do you still do clinical shifts?
Yes, I do. Yeah, I don't think I would be allowed to get away with not. I think I'd be called out by people for it.
Oh, okay.
So yeah, no, I do.
Yeah, and that's in a labour ward or in a...
Varies, and I have been known to come out and do some shifts with you as well.
Yeah.
Always terrifying, but yes, a mixed bag.
Oh, cool. Oh, that's awesome.
I'm going to come out and do a shift with you two now.
Yeah, that's it. Yeah,
bring it on, absolutely. Yeah. Anytime.
It's the only time we don't get a maternity job.
Yeah, that's probably... No, I've never had that. Every time I've gone out...
Have you not done a maternity job?
No, I've always ended up with one.
Have you?
Yeah, whoever I'm out with always rings up the control and says, Dawn's out with us today. She send us to any maternity in the UK. It's like, hang on a minute, steady on.
Okay, well, if you come out with me, we're going to keep you as a hidden asset. We're not going to tell them. We're not going to let them know that. You want a bit of normality. You want to say what the
definitely want that.
Is. Yeah.
That is where I first thought, oh my God, you lot do an amazing job. Because the first time it wasn't the first time actually, it was about the 5th or 6th time, I did a ride out. A job came in and the person I was with came running into the crew room going, we've got an obstetric emergency! And I was like, oh, that's bad. But she seemed really excited. And she was like, come on, let's go. And I was like, oh, okay, great. What is it? I don't know. And I was like, what do you mean you don't know? And she was like, well, we won't find out till we get there. It just says birth imminent. I was like, oh, okay.
Probably means birth's imminent then, doesn't it?
Well, it was a birth imminent. But when we got there, it was a lady that didn't speak any English. She was homeless and we had no idea of her gestation.
Yeah.
And so that's normal for all of you, but to my midwifery colleagues and to me on that particular day, it's a little bit like,
Yeah.
Oh my
and
gosh.
where's your folder with all of your notes?
Yes.
Yeah, exactly.
So it was fine. She birthed with us and everything ended well and we managed to get her and her very tiny baby to hospital.
Yeah.
But yeah, those sorts of things you don't have to manage in hospital as a midwife. You've got a team of people when you pull that crash bell and they all come and give you a hand.
Yeah, I suppose there's loads of like pros and cons to like being in hospital compared to an ambulance, and likewise as well to an ambulance. You know, I know that there's less people, but sometimes when there's too many cooks in the kitchen, it gets a little bit difficult.
Oh yeah. Although I don't know, like sometimes you see like the crash bell being pulled in A&E when you're like taking a patient through, and you just see all these doctors come flooding around. You're like, where were you 10 minutes ago?
Yeah,
like,
exactly.
I could have used you.
Yeah.
Like.
Well, now we know a bit about you, Dawn, so thanks for the good introduction there. So let's get into the depth of what we're going to be talking about today. So I don't know if the midwives listening know, but I think that secretly ambulance staff, we're petrified of obstetrics jobs, aren't we, Sam?
They frighten me. Yeah, absolutely. And I think that's probably due to lack of probably training to an extent, lack of awareness and identifying when something's gone wrong or is going to go wrong. I think that's where we sort of struggle, because it's not until it's probably too late that we start to go,
Yeah.
You know.
I mean, even on my tech course, we did about 4 hours of obstetrics, and then we did maybe an hour or two on theory, and then that's it. We didn't even get tested on it. It's crazy.
Also, midwives, like, I love them, but my God, are they scary as well. Like, you rock up to a labour ward with a patient, and if you've not got what they want, they're like, I'm really sorry.
Yeah.
Like, you know. And equally, they're just as, like, the same back towards, I think, like, the service users as well. You know, they are not afraid to lay the law down and tell them what's right and what's wrong, which I respect them for that as well, because that's...
But I think, like, I don't know what you think, Dawn, but another thought of mine is that because in a maternity job, there's so many different variables that you have to be thinking about. And, like, if we go to a patient having a heart attack, we know exactly what to do. We know exactly how they're going to deteriorate. And we also know what they kind of look like just before they deteriorate. And we're quite comfortable with that. But with a lady in labour, there's so many hidden things that we don't know what's going on. Like, she could be bleeding internally and we don't even know. Like, her respiratory rate might just be up a little bit, and that's all we have to go off of. And it's kind of scary. And I don't know if you agree with that, or whether you've got any other things.
Completely. And just listening to you both, it's resonated in so many ways. So let's just talk about the training aspect, because this is something that just grips me. So there's two professions that manage women in labour and childbirth, and they are midwives. Well, there's three actually: midwives, obstetricians, and then pre-hospital clinicians, so yourselves. So why on earth are you only getting 4 hours training or half a day's training? That is bonkers, absolutely bonkers. And I really hope over time, I want it to be my legacy before I retire, whenever that may be. I want it to be my legacy that I change that. Because, you know, when we speak to our international colleagues, particularly Australians, they get 6 months. 6 months maternity in their training.
That's wow.
It's mad, isn't it?
Yeah.
So how on earth are we getting away with some universities do nothing? I won't name them, but I could. And some universities give you half a day. So yeah, so that's the first thing. Second thing is, I spoke to one of our air ambulance doctors actually ages ago at a conference, and I said, you know, maternity terrifies my pre-hospital clinician colleagues, and I just don't understand why they're so frightened of it. They see so much horrendous stuff. Why is this the thing? And he went, oh, no. Let me stop you right there. I'll tell you why it's scary. And I thought, oh, okay. And he said, what we go to, he said, when we get there, it's normally already happened. He said, so we kind of know that it's already broken and we've got to fix it.
Yeah.
He said, that's all right, I haven't had to watch it ensue. He said, but your lot, i.e. my maternity patients, I'm suddenly responsible for every woman that's pregnant in the UK. He said, your lot, he said, you have to watch it unfold. Yeah. He said, you get there, it hasn't already happened. And he said, it's a bit like watching the opener for Casualty. He said, you know that the man on the scaffolding is going to fall from height. He said, I feel like that when I go to your patients. He said, I've got to watch that horrendous thing happen, and it goes from flash to bang really quickly. And I was like, okay, now that does actually make more sense. And we're not in an environment where we can always necessarily make it, you know, fix it quickly.
Yeah, that's so true, actually.
And I think there's so many, like you said, you know, variable sort of ways it could go wrong or go, not quite right on the way to the baby coming out.
I mean, a normal birth, right? Let's not over medicalise childbirth, because absolutely, you know, the woman that's had one baby before, and I always say this in my training, never take your eyes off a para one. So somebody that's had one baby before, we kind of know that baby number 2 is the quickest, even if you have 20. That one's probably going to be fine. If you're going to a birth imminent, which is, for midwives listening, that is a call for a woman in labour and potentially about to birth. If you're going to a birth imminent and she's a para 1, you're probably going to have, I don't want to doom myself and my colleagues, but you're probably going to have a nice birth, a nice delivery. It's going to be that euphoric job.
Yeah.
But we know, and this is also madness, that midwives will only go out to a woman who's over 37 weeks and booked for a home birth in most trusts, not all trusts. So actually that means that my clinician colleagues that have had half a day's training are going out to all the very complex women that are under 37 weeks. Now, how is that right?
Yeah, it's just completely wrong, isn't it? Yeah.
Utter bonkers.
That is crazy. So for all of the people listening, probably not midwives, but the ambulance people.
Midwives are sat there with their feet up, like in the pocket,
going,
like,
what are you talking
why are you
about?
stressing?
Yeah.
Why are you stressing?
But like, so for the ambulance people listening to this podcast and going, I'm a little bit apprehensive that at work tomorrow I am going to go to a lady in labour. They're fearful of it. Have you got any tips on how to reduce our fear of maternity jobs?
Yeah. Okay. So in short, no, I guess, because I'm always anxious, even with my experience going to a maternity job, even if I think it's a para one that's an imminent birth, I'm still running through in my mind, and I think it's right that I'm running through in my mind, by the way. Right, okay, so this could be this, it could be that, it could be the other. If this plays out, what am I going to do? And also, what the difficulty with pre-hospital management is, I don't know what the address is going to look like. I don't know what the house is going to be like. I don't know what room she's going to be in. She might be on the 16th floor of a tower block. The lift might not be working. So there's so many other complexities, aren't there, that actually make it more stressful. So I completely get it. And I think the day that any pre-hospital clinician says, I love maternity, is the day that they might not quite have it right. Because as you both said, it can unfold really quickly. So I think we should always be on edge for these jobs. We can stand down from being on edge once the baby's been born and the mum is well and the baby is well. We can wait for the placenta. I don't want any pre-hospital clinicians to be delivering placentas. Really need to stop doing that. But once mum and baby are both fine, then we can have that moment of, okay, I'm still going to be on alert, because history has told me that actually you can still bleed 10, 15, 20, 30 minutes after you've had a baby, but I'm slightly more relaxed.
It's nice, it's reassuring to know that even you have certain anxieties around something that you're such a specialist in. So at least then we can go, oh, it doesn't matter that I'm so fearful of these jobs, because Dawn is a little bit as well.
Yeah, a lot of it, not a little bit, a lot of it.
Yeah.
So moving on then, I think that as ambulance staff, generally clinically, we kind of know what we're doing, or if we don't, we've got everything to hand. We've got our little Bible on an app, which is the JR Calc, which we can just press a couple of buttons and we know exactly what we're doing. What the JR Calc doesn't talk about, though, is how to communicate with patients generally, especially women in labour, which I think is probably up there with the highest acuity of patients that need communicating with well. So, and I've done a lot of reading into this once, when my girlfriend gave birth to my baby, and I learnt a lot about the scales of adrenaline and endorphins, and how you need endorphins to be able to relax and progress the labour. But then when an ambulance crew or someone like the dad bowls in, rushes in, starts sort of making hasty comments or being stressy, that increases her adrenaline, and then it reduces the endorphins, blah, blah, blah. So I've been there countless of times where we've gone in, we've bowled in, and we've gone, right, get off the toilet, you're coming into the ambulance. And the lady's like, oh my God, what's going on? And then she's panicking, and then they're like, don't worry about the bags, just go. We don't want this baby being delivered in our hands. That's just is going to reduce the endorphins and increase the adrenaline, right? So how much do you think we should be trying to think about the endorphin adrenaline scale? Because I know that there's an aspect of the fact that there could be something going on that's making the mum or baby critically unwell. So how much do you think we should use those scales to how we deal with the mum?
Yeah, so you raise a really good point. So we know that the hormone oxytocin that makes us contract will start to fall, and your contractions might disappear if you're really stressed. So let's not lose sight of that. However, I'm going to caveat that with, if someone has declared an emergency, i.e. they've dialed 999, let's put this into perspective. You have declared a medical emergency, and for that reason, I need to see you, and I need to have what we call eyes on, don't we, in the pre-hospital setting. Yeah. I need to expose you and have a look. So I'm always really guarded to say, you can't put the lights on, you can't see her, you can't do this, because actually this is different. This isn't normal midwifery. Now, if I'm looking after somebody on the birth centre, I'm really mindful of all of those things you've just said, and I want to keep the environment really warm, really comfortable, really quiet, music, all of those things that will keep a woman relaxed are really important. But the minute you declare an emergency, unfortunately, that does switch change. And so I think sometimes as midwives, we lose sight of the fact that if an ambulance has been called, you have a professional responsibility for the patient too. So opening the front door and saying, can you wait out there just in case, and slamming the door in your face is unacceptable, and we're not a standby service. Asking you to come in and wait in the kitchen, also unacceptable. Those people shouldn't have called an ambulance.
Yeah.
So you only dial 999 if there's a problem, and if there's a problem, I absolutely want to see the patient, because we all know, and we've all had jobs pre-hospitally where things have gone horribly wrong, and you've got to constantly think, and I feel awful saying this, but I've constantly got in the back of my mind, what would the coroner say that I didn't turn the light on and I didn't look at the patient? Because we've got joint responsibility now. If I've called you to a woman, the minute you walk into that home, you've got a professional responsibility to her too. So collectively,
our patient.
Collectively, it's our patient. I don't own her; she's not mine, and I also don't pull rank, because midwives are not more senior than pre-hospital clinicians. We might have a discussion collectively and say, particularly if, say, a woman's birthed and the baby's not breathing, I might say to you, do you want to take baby? Because I know that historically, and forgive me for this, you're resuscitation experts, you're probably going to be more comfortable resuscitating the baby. And shall I look after mum?
Yeah.
But you might say to me, no, actually, I'm really happy to go and care for mum. I don't think so. But you might say that and you resuscitate the baby. But we have that discussion, right? And we look at each other's epaulets and we say, right, what's your grade? Okay, yeah. What do you want to do? This is the situation. But I also expect that you want a handover. I can't bear it when I walk into a job, and obviously I wear green now, so I also look like a paramedic. And people don't hand over to us, and I'm on the other side of it, and I'm seeing how you guys get treated, and it's not acceptable. I expect a handover when I arrive, and if everything's fine, that's great. Of course we'll wait, but what are we waiting for? Because if you're ringing me because you know that the heartbeat's really, really low, and with the next couple of pushes the baby's going to be born and we think the baby's going to need full resus, no problem at all. That's what we're here for. But if you've called us because last time she bled a bit, that's not okay.
Yeah.
That's not what we're here for.
When you've come across those sort of situations in the past with other midwifery colleagues, do you take the chance, if you get the opportunity, to sort of debrief with them afterwards and say this could have gone better because of A, B, and C, or do you just sort of walk away and leave it as is?
No. I use it as an opportunity, because there's always learning, isn't there? And the best learning is perhaps when we don't get things always bang on. So even if I'm not on scene, even if I haven't been at that job, if crews ring me and tell me about a time that it didn't quite work as it could have done in terms of teamwork, then I'll always try and get hold of those colleagues, midwifery or green people as we refer to them, and I'll always try and do a friendly, approachable debrief, because like I say, that's how we get our learning. Otherwise you're going to go out and do the same thing again.
Yeah, absolutely.
And so that's what we don't want, isn't it?
Yeah, that's quite interesting, and I think it's important that when you realise, well, not when you realise, but when you made us realise really, that actually what we're going into is potentially an emergency. It's not a birth centre. It's not this. It's the complete unknown, isn't it? And that's probably why we do have to go. No. I need to get eyes onto this. Another thing that I wanted to touch upon is ambulance people generally, we're suckers for a set of observations, right? And in every
get the vital signs in. Yeah, absolutely.
we will go to a 20-year-old with some chest pain, right? And he's hurt his chest because he's done some digging in the garden and pull his chest. And there are paramedics out there that will check his blood glucose level. Wrongly or rightly, I'm not going to have that argument now. But I've been, in the pre-hospital world, it's not something that we come across every day, a maternity job. But the ones that I have been to, we've bowled in, and this lady's on all fours, sort of having the urge to push, and you got a paramedic sort of wrapping a blood pressure cuff around her arm. Is how important is a set of observations in someone? I understand if you've got someone that's hemorrhaging and they're really sort of pale and they've got a reduced GCS, you're going to want to get a set of obs on them. But in an uncomplicated labour, when someone is pretty much in the last,
they're going through that natural process of birth.
Yeah. How important is a set of obs right now?
Okay, so I get it. And in actual fact, I'm going to be really careful about how I answer this one, because I know that my ambulance clinician colleagues, the expectation is they will get a set of obs. But it's about timing, isn't it?
Yeah.
And it's about how and when you can achieve that. So ultimately, midwives should have been doing sets of obs on the woman whilst she's in labour, and even in the second stage when she's pushing. So if I walked into a woman and there were midwives on scene, I'd probably ask for the obs, the most recent set of obs, and that would be perfectly acceptable. If I've walked into a woman and she is birthing and I'm first on scene as a green person, then obs are not at the forefront of my mind. Yeah. I'm going to put a pair of gloves on and I'm going to assess her and I'm going to get ready for her to push. Because we know that women, when they arrive at a place of safety, i.e. hospital, or when pre-hospital clinicians arrive in their home, that happy hormone is released and they go, it's safe now, I can birth. And women will often follow through and birth for us. So I know that when I arrive on scene as a green person, not necessarily as a midwife, that woman might relax and just produce a baby. So my first priority is not my obs, but at my next available opportunity, or perhaps when the second truck arrives, I might say to a colleague just immediately post-delivery, could you just do a quick BP for me?
Yeah.
If she's bleeding, again, really important to get a baseline set of obs. But if I've walked in and her circulating blood volume's on the floor, I really don't need to do a blood pressure to know that it's really bad.
Yeah.
Exactly. So my first priority is probably going to be to massage her uterus and to try and stop the bleeding. And then again, at my first available opportunity that a colleague might arrive, I'm going to say, could you just do a quick BP for a baseline? But I can feel a pulse and rub up a contraction simultaneously. Yeah, so, that's true, and actually I want to know what her heart rate is, because if she's tachycardic, we know, don't we? You will definitely have done the same thing.
Yeah.
Oh yeah. Guilty.
And it's like I suppose, and that's an indication. I mean, you can just look at people and tell they're unwell. You don't need to see their blood pressure.
Yeah, it's that classic end of the bed scenario, isn't it, where you just look at the patient and you gauge it just from looking at them.
But you're both experienced clinicians, so perhaps for some of our newly qualified clinicians, they are all about trying to make sure everything's as it needs to be in the notes. So I get it. I get why they really want to do a set of obs. And going back to your blood glucose comment, God love them. They're task focused. Yeah. They need to do a blood sugar. Yeah. The fact that the patient has absolutely no need for a blood sugar doesn't enter into their conscience. But as they become more experienced clinicians, that's then when they'll admit it, because they'll know that they can justify and mitigate.
Yeah, that's very true.
It's like, we need to do a full set of obs. Check his pupils. Why are you checking his pupils? He's got chest pain. That's it.
I'm sure her GCS is 15. But
the head's out, mate. I don't think. I don't think it's going to help.
We've got a real issue as ambulance clinicians about going down the pointy end, as I've heard it referred to, which really slays me every time I hear it. Nobody likes to have a look, and it's like, you've got to have a look, because pre-hospitally babies only come out of vaginas, they don't come out of abdomens unless you've got cesarean skills I don't know about. So you're going to have to say to her, can I have a look? And she doesn't care. Yeah. I'll promise you she doesn't care.
No, I think at that point, I mean, because that's one thing that I thought about when my girlfriend was in labour. I was like, God, she's going to, bless her, she's going to be so embarrassed of all these people looking at her. But no. She didn't care. It all goes out the window. But talking about pre-hospital cesareans, that's coming to jail. No, I'm joking. It's not coming to jail.
It's like, what?
Yeah, no.
Hems only skill, tough cuts out straight down the belly.
Can you imagine?
First week I started, I was asked that by a senior clinician who will remain nameless, and you both know him. And he said to me, can you teach paramedics to do perimortem cesareans? And it was the most hilarious starter to the ambulance service. And I was like, I don't even need to think about that. No.
I think so I did a maternity placement as part of my paramedic course, and I spent a week up there, and my God, I think C-sections are the most brutal thing ever. I'd never seen one before, and they invited me in to watch this one, and I was watching it, and then they make the incision, and then they just put the scalpel down and they just start tearing. And I'm like, oh my God, I'm looking at this doctor, I'm like, use your knife, mate. What are you doing? Why are you being so horrible? You've got a knife.
And, don't they do that because it heals?
Yeah, it heals better. Yeah, it heals the tissue heals better when they tear. But I was like, oh my God, because I hadn't had that explained to me. So I'm like, why is he trying to rip her stomach open?
Yeah. I was horrified by how small the incision is. Yeah. Because I thought, well, why are you wrestling the baby out? Just make it bigger. Yeah. And then of course they then said, yeah, but the woman doesn't really want a long scar. She wants it to be in her bikini line. And I was like, oh right, okay, fair enough.
Crack on, mate.
Yeah, you know best. You know best.
Yeah, that's it. So, should labour be more difficult just because it's at home? So, when we arrive on scene, generally it's a bit of a panic. That we've been called because they don't know what to do. So if the mum wants to jump into the bath to deliver the baby, for example, should we be advocating that, or should we be going, no, you've called an ambulance,
get on the truck, let's go, which is what a lot of
or get on the bed
people
or something,
do.
because that's easier for us to deliver the baby.
Yeah, so if the family have called us, which is I think what you're inferring, isn't it? If the family have called us, then why have they called us? Are we being called as a simple maternity taxi, which we know that's what we get called for quite a lot, in which case, no, you're not getting in the bath, we're going to hospital. If she's booked home birth, then I would be asking, is the midwife coming? Have you called the midwifery team? Do they know? But I certainly wouldn't be letting her get into water until the midwives are present. So training to do water births is part of midwifery practice, and it's not something that we do as pre-hospital clinicians.
Okay.
So it's quite specific, and yeah, you'd need a midwife to allow a woman to birth in water.
Yeah, that makes sense. Or at least we know that, because I've never had this before, but I'd always thought to myself, if she wanted to jump in the bath, I'd probably go, yeah,
same. I wouldn't have known to say no, actually.
Yeah,
I'd be like,
that's a
well,
good
they
point.
say let the women do what they've got to do. It's their process. Like,
and I suppose
There's a midwife.
If there's a midwife,
Absolutely.
okay, fair.
Yeah. No, not for us.
and so there's complications that can come with that for the birth. Fine, no, that makes sense. So yeah, remember that, everyone. Don't advise them to go in the bath.
And if they're in the bath, ask her to step out because you're not trained in water birth.
Yeah, there you go. And also we'd need the heart team because there's water involved.
James, you're up.
We don't have life jackets. So and also another thing that I wanted to touch upon is that I've been to a lady in labour before, and I just automatically started unzipping the enternox. And she said...
I was wondering where you're going. I thought, automatically started unzipping. I was like, unzipping what, Tommy?
Oh, we're not going to get into that. And she said to me, I don't want that. And I said, okay, that's fine. Just breathe or whatever you want to do. And the person I was with, who was the senior clinician on the ambulance, said, no, you need to suck this in because this is going to help with your pain. And then it all turned out that in the whole plan, even though it had gone a bit wrong at this point, she still didn't want pain relief, and that was her plan throughout the whole birth. And is that okay if they don't want to have paracetamol or Entonox? Is that okay? And we should be going, okay, fair enough. Well, it's there if you want it.
Yeah, absolutely. So I was one of those crazy people.
Oh, there you go.
I didn't want to have anything, and I did try the Gasonair or Entonox, but I didn't get on with it. So yeah, there will be women out there that want to just try and experience the birth as it is, and that's okay. But I think it's, as you just said, it's quite nice to remind them that it's there if they change their mind. But yeah, no, you don't have to have it.
There you go.
Well, I mean, it's consent, isn't it? You can't force it upon someone.
And I just felt really sorry for her. And then she ended up chugging away on this Entonox, and I just thought to myself, that poor woman, she's probably built this moment up of childbirth for years, as most women do.
Yeah.
And this... Actually, I nearly swore there. I don't care. This an ambulance person has just come along and just shoved an Entonox filter cap in her mouth.
Yeah, that's less than That's worse than turning the lights on, to be honest.
And then, obviously, generally we worry about two patients in a maternity job.
Yeah.
One being the mum, one being the baby.
Yeah.
How much of the birthing partner or the father, in a lot of cases, should we be involving in the whole process? And also maybe look at them as also a potential patient in that scenario.
Yeah, they have become patients once or twice, haven't they? So I think the partner needs to be really included, and I don't think we're always very good at this. And that applies to hospital midwifery as well as pre-hospital ambulance clinicians. And I think it might depend on experience. So if you're very newly qualified, it's too much for you to have to focus on them as well. You've got all these things you've got to do, and you've got to remember all of them in a specific order. And, woe betide you that you might forget something. So I can see how they become a bit of sort of an afterthought or a bit forgotten. However, as you get more and more experienced, I think you relax a little more, that actually you can use them to your advantage. And particularly if you've got a bit of a chaotic scene, or you've got a mum that's really distressed, coach them, give them some tips on how they can help. I think it's probably quite good at this point to say also that if you advise a partner to massage the back of the pregnant person who's birthing, it might be that they get a right hook, whereas you wouldn't have. Because sometimes as women birthing, we're not very kind to our partners, and we need to be mindful of that and just reassure the partner that actually, yeah, I know that this lovely demure person that normally has never sworn before in her life is now effing and jeffing like you've never heard before. They will become normal again. This is kind of what labour does to us. And whatever you do is going to be wrong. But I try to involve them. And if I've got a woman who is finding something particularly difficult, I'll try and channel their energy into helping, or I'll give them some tasks to do. Certainly if you arrive on scene and it's chaotic and the baby's coming, I'll always go and get them to get a load of towels, bung them in a tumble dryer, put them on a radiator, give them a practical task to do. Try not to send them off miles away so that they're not there when their spawn arrives.
Yeah.
But
drive to Tesco.
no, don't do that. Go and buy us all nice biscuits and sandwiches. No, don't do that. But yeah, I think we do forget them. I think you've raised a really valid point, particularly when things are perhaps going a little bit south and we're becoming very task focused on what we need to do. I've had so many partners say to me it was horrific because they literally watched everything ensue and they couldn't help and they felt utterly helpless. So in that situation, and I imagine you guys have way more experience this than me, in that situation I try to involve them as best I can. It's probably the same with parents when you go to children.
Yeah, I think it depends how many clinicians you've got free on scene, doesn't it? And like if you've got one that's spare that you can lend to just care of the father, then do it. Do you know what I mean? I think that's going to benefit everyone.
It's the same, I suppose, in any sort of difficult situation. Like cardiac arrests are a big one, just a bog standard, your normal medical cardiac arrest. You've normally got a family member who's found them and they've done all of the work, they've found them, they've started the CPR, they've called the ambulance, and then we get there, shove them into another room and go, right, off you go, we're gonna do our bit now. When I think it's changed a lot now where we're integrating them more into the decision, even the families into decision making, you know, and things like that, which I think is pretty good.
Do you know what? That's just reminded me of a really nice thing that one of our colleagues did, and we shouldn't ever lose sight of this, so I'll raise it here if you don't mind. So we went into a baby that was, I can't remember how old, I want to say 2 days or may have been a week old, and was in an arrest. And the dad had started CPR as instructed by our control room colleagues and was doing a great job. And the 2 critical care paramedics that arrived on scene first, just a complete throwaway comment, said to this dad, "You're doing a really good job there, mate. Are you all right to carry on whilst we do a quick kit dump and get everything ready?" Which is a completely innocuous comment.
Yeah.
And we'd all say it. And unfortunately, the baby's outcome was poor. But afterwards, after the investigation into why this poor little mite passed away, the investigators came back to me and said, "Oh, there's one bit of feedback I'd just like you to give to your 2 colleagues that were first on scene." And I was like, "Oh, okay." And they said the dad said that he had found it so much easier to recover, however that is, in this horrific situation, because he felt that he'd done everything he could for his little boy. And it was that comment that helped him to go, "Do you know what, I did everything I could for my little boy." And that man that walked in said I was doing a really good job. And it really it warmed my heart, because I just thought that's something that you or I would probably say as a throwaway comment and perhaps not give it a second thought. But now I really think about it, because it was really helpful in this scenario. It worked to the benefit of this family. But actually that could have gone the other way. But in this particular case, we'll celebrate it, because that's great. If that helped that dad to recover from that, that's brilliant, isn't it?
No, 100%. And I do the same. And I think a lot of people do. There's always the relatives who go, "Oh, could I have done anything better?" And even if they could have done, I always go, "Do you know what? You did really well. Like, you did everything. You did more than what I would have done if it was my mum."
It's probably like an unconscious practice, isn't it? You just do it without thinking, like you said.
Yeah, that's it. And another thing that we want to touch upon is J.R. Calc talks about when we cut the cord, and this is pre-hospital, sort of in an ambulance or in someone's house. So the baby's born, and J.R. Calc says that you should wait for it to stop pulsating or turn white, and at least 60 seconds, unless there's like an emergency, we're presuming that the baby's okay. Wait at least 60 seconds, or wait until the cord is pulsating or turns white before you cut it. Another thing that I've read upon in some what people like to do is delayed cord clamping, and that can be like 10 minutes, half an hour. What's your thoughts on it? Are there benefits? Are there risks? And also, should we advocate that?
So the delayed cord clamping is actually The evidence says 60 seconds. And so certainly in a time critical and emergency, it would take you 60 seconds to dry your baby and get rid of your wet towel. So the first part of the newborn resuscitation algorithm is to dry your baby and stimulate. Now, by the time you've dried your baby from top to toe, and possibly mum's abdomen as well, because I'm guessing that's where baby has probably been placed initially, I would say 60 seconds has elapsed. And then you've got rid of your wet towel, you've put a hat on your baby, and you've reached for your dry towel. Now that's really, really important. Those 2 steps are absolutely essential because we know that babies can't thermoregulate. Yeah. And for every degree below 36.5 that their temperature drops, their mortality increases by 28%.
Blimey, I didn't know that.
So if you've got a cold baby, you won't be able to resuscitate it. It doesn't matter how good your ventilation skills are, you will not be able to resuscitate that baby. And that's in a term baby. In a preterm baby, it can be as high as 80% mortality if you don't keep it warm.
Jeez.
So I always say, by the time you've done that, 60 seconds has elapsed. So if your baby is still not doing what it should do, i.e. you've stimulated it and it's not breathing spontaneously, then at that point you should definitely be clamping and cutting and taking your baby to wherever your resus area is. That's the worst case scenario. In a best case scenario where you've gone in and mum has birthed and everything's lovely and the baby's screaming its lungs out and it's really healthy and it's gone pink and all of those things, then yeah, wait longer. There is no harm that can come from waiting longer. And in fact, as you rightly said, there's a lot of benefit to it. And the benefits are that the baby gets that surge of blood from the placenta. So you're preloading them with red cells and iron. So you're giving them a nice iron-rich blood supply. So they're less likely to need a blood transfusion. And there's some evidence to say that it helps with brain development. So ultimately, you're doing this baby an absolute favour. What we shouldn't be doing is milking the cord. So as pre-hospital clinicians, they might do it in hospital and you might see an neonatologist do it, but it needs to be done correctly. And what I must sort of try and get across here is that as pre-hospital clinicians, we shouldn't be milking the cord, which is pushing the blood from the cord towards the baby. We shouldn't be doing that in the pre-hospital setting. 60 seconds, clamp and cut if your baby's not breathing. If everything's fine, you can wait 5 minutes. And parents will often say, can you wait for it to stop pulsating? Or can we just leave it well alone? Yeah, absolutely fine. The only limitations you've got then are the length of the cord that you've been given, because it might be short. In fact, one of our colleagues emailed me last week and said she had that very problem and she didn't know what to do because she couldn't lift the baby onto the mum. And again, the warmest place in the room is mum. Yeah. She is as hot as toast. She's just literally given birth. So the best place you can put your baby is straight onto mum, skin to skin. And she did the right thing. She lifted the baby onto the mum, as low down onto her abdomen. In that scenario, I think from a practicality perspective, I might wait 2 or 3 minutes and then clamp and cut, just so that the baby can go up onto mum and be kept warm, because that's also really important.
Yeah, I suppose you have to weigh up what the baby's going to need, and if it's to the point where you can't even get them up, then I suppose And
how are you going to leave scene? So I've had midwives say to some of our colleagues, don't clamp and cut the cord, whatever you do, like it's going to explode or something. And it's like, why on earth would midwives tell ambulance clinicians not to touch the cord? There's a reason you've got cord clamps and scissors in your packs. And perhaps my midwifery colleagues in a hospital haven't considered how difficult it is to actually get a woman out of a 16th floor block of flats while still attached, navigate the stairs or wherever. Yeah. So maybe they're thinking about how we would do it in a hospital, and that would be correct. But pre-hospitally, no, I think you need to separate the two, not least of which because you need to put them in 2 separate trucks.
Yeah, that's it. It's mad, isn't it? Like the logistics of trying to sort out who's going to go where, what's going to go, and stuff like that. It can be quite complicated. Another thing that's on the rise, just generally, is hypnobirthing. I've read a bit about it, and it's quite interesting. But is it important for ambulance staff to learn about it? And if they're hypnobirthing when we arrive, is it something that we should sort of go along with, or is it something that we should be saying, hang on a second, that's kind of out the window now, we need to intervene? Yeah,
so I think I'll circle back to the previous point about when we enter and adrenaline, etc., and endorphins, etc. So if a woman has chosen to hypnobirth, the likelihood is she'll be very silent and she won't want to converse with you. So there may be somebody on scene, possibly the partner, possibly a doula, that will be saying that they're the advocate and you may need to speak through them. Now, no problem if we're in a low risk birth setting and everything's planned, that's great. But again, why is an ambulance being called? So immediately I'm thinking, well, there must be a problem, the fact that we've called an ambulance. Otherwise, probably you shouldn't have called one.
Yeah.
And if you called an ambulance, quite rightly, we want to be able to talk to the mum. And we need to be able to say, are you okay? What's happening? What are we trying to do? Now, if at that point you're informed that she's hypnobirthing and we just want a lift to the hospital, don't get me started on that, then you might be really lovely and say, okay, let's get you into the ambulance and let's get you to where you need to be. That's a whole different episode.
Yeah, we should put a podcast out to the public, shouldn't we?
We really should. We are not a maternity taxi.
Yeah.
In an emergency, please call us, but we are not a maternity taxi service. So yeah, I think you don't need to learn about it. There may be midwives on scene already that may have called us because we need to transfer the woman in because maybe she's stopped progressing in labour. That might be something, in which case the midwives will manage that aspect. And again, we're probably being called as transport experts, and sometimes we have to roll with that, don't we? And I would just let the midwife manage the hypnobirthing. But yeah, I don't think we need to read about it. I think the important thing to say for pre-hospital clinicians is mum won't want to speak to you very much because she'll want to get in the zone. And it's how you manage that to the best of your ability, whilst also recognising the fact that you've been called as an emergency.
Yeah, no, that makes sense. Because I know that when my girlfriend was having her antenatal sort of appointments when she was pregnant, when you ticked what pain relief you wanted, hypnobirthing was one of the tick boxes for pain relief.
Is it? Oh, really?
How mad is that? So you literally had the opioid injection, I can't remember what it's called, Entonox, blah blah. Oh, there you go, Pefidin. and then at the bottom, or mixed in, hypnobirthing, and I was like, that is crazy. That's like an official form of pain relief that they say.
So moving on, we were going to just ask you, in regards to sort of bereavement care and breaking bad news. Obviously it's very different from breaking bad news in your sort of standard adult elderly cardiac arrest to that of like a stillborn or a newborn that or baby that goes into arrest. What sort of training do you think ambulance staff should receive in regards to bereavement care and breaking bad news to parents of stillborns?
Gosh, so I think there's lots of training to be had in this. And how do we learn this? So I think I learned it from watching colleagues do it well and probably do it badly, actually. And that probably doesn't change from ambulance service to hospital. It's not something you can necessarily teach, although there are some definite do's and don'ts. So I've heard people say when someone's lost a baby, oh, don't worry, at least you know you can get pregnant. Now that is just like the thing of all things that you don't say, isn't it? And on the flip side, I've heard people manage it really well. So I personally don't think we should be calling it on scene. I think it should be a multidisciplinary approach in ED. The only time that we can call it, as it were, is if the baby is under 22 weeks gestation and it's therefore not viable and it's not going to survive. And in that circumstance, it's in JR Calc now that any baby under 22 weeks is not for resuscitation. And in our service, we've got some really nice little pockets that we can place the babies. I mean, arguably, some people would say products of conception. I think if it looks like a baby, I refer to it as a baby. And then I would try and suggest to the parents that they hold it. But I caveat that with, if the woman's birthing as I arrive on scene and she says she's 21 weeks, say, then I'm not going to ask her in that moment if she wants to hold the baby when it's born, because she has got in her head all sorts of horror. And our imagination is way worse than reality usually, isn't it? And so I would say, we're going to care for you, and if the baby is born, I'm really sorry, but I won't be resuscitating the baby because it's just not old enough, it's not going to survive, the lungs aren't mature enough. I'd use that sort of language to try and convey the message. However, the baby may come out and it may do some little what we call non-viable movements. And what I think would be really good is if you could perhaps hold the baby if you felt you wanted to, but if you don't, that's fine. I or one of my colleagues will hold the baby for you. And then at the point the baby comes out, it's at that point that you need to reassure her that it looks normal like a baby. Because I think women have it in their head that they've birthed the Frankenstein's monster. And obviously that's not the case, is it? So I'll always try and encourage women or partners to hold the baby and then get them into definitive care as quick as possible. You can't really say anything right or wrong in this scenario. So what I say to some of our colleagues that really, really struggle with it is, it's perfectly fine to say to somebody, I honestly can't imagine how awful this is, and I am so sorry. And if I'm honest, I don't know what to say, but I want you to know that I'm here for you and I'll do whatever I can to support you whilst we get you to hospital. End of. Period. That's it. That's all you need to say. Tell somebody you don't know what to say, but certainly never, and I've seen colleagues do this as well, certainly never say, oh yeah, no, I had a miscarriage as well. You hear people say that. No. You can't compare apples and pears. Yeah. Whatever your personal experience is, and every woman will have their own personal experience, that woman's not interested in your experience
today.
It's not your moment.
It's hers,
this is her moment, and this is about wrapping her up and being kind, and actually saying nothing sometimes is okay. What's that Mark Twain quote? Better to say nothing and appear stupid than to open one's mouth and remove all doubt.
Yeah, that's so true. And still saying, look, I don't know what to say. I can't even begin to understand what you're going through right now. I suppose that's a way of empathising with them, because that's quite a powerful meaning behind it. To go, do you know what? Even I can't imagine what you're going through right now.
I think it brings that sort of human compassion down to, we're not just these people in green or blue or red or whatever colour you're wearing. We are human, and we're here with you too in this moment, to support you as best we can.
But we're going to look after you.
Yeah. Absolutely. And that's what they want. They just want to feel looked after and cared for.
Absolutely.
Don't they?
Absolutely.
So when we break bad news to relatives of a dead adult, there are tools that we can use, there's acronyms that we can refer to when sort of going through a process of talking to them, giving them some time after the initial hit and stuff like that. Is there anything like that out there when it comes to these sort of the premature before 22 weeks, or is it kind of follow the same kind of...
I think follow the same. I'm not aware of any. I've never been taught that. But yeah, if they are out there, then they're probably transferable, aren't they?
Yeah.
I would imagine. Yeah, I don't know the answer to that.
No, that's okay. Well, no, I suppose you did answer it because I suppose they might be transferable. Yeah. I don't know them off the top of my head, but I know that hospice staff have been trained in them quite a lot.
That's interesting.
So
I might have to go away and read that myself.
Yeah, no, they're quite interesting tools to look at.
You're going to have to reference yourself now, Tommy.
Yeah, that's it, yeah.
Well, obviously I want to know because I want to go and read it.
I can't retain information, unfortunately, so yeah. So when we've got a newborn baby, is there any really easy ways to remember, or again, going back to acronyms and things, to spot an unwell newborn?
So there's a few markers that we use. So I always want to know that the baby's feeding well and it's weeing and pooing. So those are the first two things I'm going to ask a parent. I am going to look at the colour. Now this is tricky because obviously some people have got darker skin tone and some people have got lighter skin tone. And we used to talk about white babies and blue babies and pink babies, but actually that's no good, is it? If you're a black origin, that's not going to work. So now we talk about what's normal for that particular baby. So if it's a Caucasian baby, yes, I'm going to ask, and I have been known to ask this to crews, is the baby blue or white? And you know as well as I do, a blue baby I'm happy with, a white baby I'm less happy with. Yeah. I'm going to have to work a lot harder to get that baby back to blue, back to pink. And in somebody with a darker skin tone, I always describe their skin colour as kind of a sort of a grey and ashen and pale. They're just not right. And the parents, particularly if you've gone into a baby that is a few days old, they're already in tune with what their baby's doing and what's normal for them. And if a parent says to you, they're not handling right or they're not doing something right, oh my God, they know best. They know their child. They're spending every waking moment with it. Yeah. And I'll never dismiss that because a parent absolutely knows best. And if a parent is saying to you there's something wrong, I'm never going to be so arrogant as to go, well, I think everything's fine actually, and I just think it's you being a new parent. Absolutely no way. Never fall into that trap. It's always worth taking a baby in and getting it reviewed by a paediatrician. My paediatric colleagues will hate me for saying that, but it's really important because some of these babies are really subtle.
Yeah.
A jaundiced baby, there's another thing. Have a little look, pull their eyes down, pull their lids down and have a little look in the pinks of the eyes and the whites of the eyes. If the whites are yellow, get that baby and get it looked at.
Yeah.
Jaundice is another thing that might be a sign that this baby's not feeling too great.
Yeah, and it's quite more common than people think, isn't it, jaundice babies? Yeah.
But yeah, feeding, pooing, not handling correctly.
Yeah, and also going back to listening to what the mum's concerns are, I've read quite a lot about, the paediatric assessment triangle, and people break down the different points. And under appearance, they talk about the mum's concerns, and that alone is a red flag to take them to A&E. So if you've got a kid with a runny nose, and you think they've got a runny nose, they've got a bit of a cold, but the mum's really concerned about some weird thing, that's, for a lot of people, that's bad enough to then take them to take that kid to
I
A&E.
always sort of lean on the parents, because I'm like, well, do you know what? They know their child best. Every child is different, and if that parent says this is really abnormal for my child, I'm like, all right, I'm not an expert, so let's go get them looked at by an expert.
We're generalists in the ambulance service.
Exactly.
Go and see a specialist. It might be that everything's fine, but do you know what? For those parents as well, just reassure them. Give them the reassurance. It's the same when women ring triage, actually, when they're pregnant, and they say, oh, you know what? Baby's just not moved as much as it normally does. And they're trying, as they're saying it to you, they're trying to talk themselves out of ringing you. They're like, oh, I don't know why I've rung you. I probably shouldn't have. It's like, no. You're not going to sleep tonight. And now you've told me that little ditty, I'm not going to sleep tonight either. So you get yourself in here. I need you to be here for half an hour tops, maybe 40 minutes. And hopefully, provided it's not busy, to all my poor midwifery colleagues out there going, you'll be lucky, you get seen in 30 minutes. Let's just do that quick reassurance, and then everybody sleeps well tonight.
And so, going back to actual maternity jobs on an ambulance, what do you think? I'm sure you audit a lot of jobs that ambulance people go to in terms of maternity and stuff like that. What things do you think that generally we can improve on a maternity job? I'm
going to add to that as well. And what gripes do you have with us? Like, what really gets you going, God, paramedics, or what really? Yeah.
None of you gripe me, because I think you do an incredibly challenging job under incredibly difficult circumstances. So none of you gripe me ever. The obvious things are bad conduct. Obviously, that's going to gripe me all day long, because I consider that I'm professional, and I like to think that anybody that represents me is the same. Yeah. But in terms of clinically, let's think about that for a minute. So it's not a gripe, it's more maybe a misconception, is that we seem to be hanging around on scene trying to deliver placentas, and we shouldn't be doing that. So we do the emergency bit. She can't stop the baby coming, so we've got to help with that, but we shouldn't then delay on scene for an hour waiting for a placenta. We should be going to definitive care, because ultimately she wasn't planning a home birth, so we should go into hospital. So that's one thing that if I could change tomorrow I would. And the second thing, let's not do a long list, second thing is women who are pregnant who have a bleed. So often people consider that bleeding in pregnancy is normal, and that, she's pregnant, that's okay. It's absolutely not okay. Any woman that bleeds in pregnancy needs to be reviewed in a hospital, a maternity unit, because there's potentially something quite seriously going on there. So those two things. Don't stay on scene to deliver a placenta, and if a woman's bleeding, take her to hospital. Oh,
there you go. Well, at least I was a bit worried there that you were going to go on for about 2 hours. These are the things that you need to do.
And reason number 99.
Not in a million years, because in the main, you guys do a phenomenal job. Absolutely amazing. And you know how much I love you.
Oh, Tommy's head's not going to be able to get out the door now.
No, that's it. Yeah, it's getting bigger. Not that my forehead could get any bigger with my receding hairline. But no, so a lot of trust, and I've only recently learnt this through the university course that I'm doing, is that you don't have to take all pregnant women who are bleeding to A&E. And what we can do is we've got numbers for early pregnancy units, and we can ring them up and go, look, we've got this lady, she's, 14 weeks pregnant and she's bleeding. All of her obs are okay. She appears quite well. Can we bring her to you? And they go, yeah, bring her in. And stuff, rather than taking her to A&E.
Yeah, it's not a nice place.
And they're not going to have anyone that can really do anything.
No, they're not. And having worked there, I can absolutely say that. No, early pregnancy units are the best place to take these women, but unfortunately, not everybody's got self-referral or a HCP referral service.
And they're not 24 hours either, are they?
No, they're not. They're kind of 9 to 5, Monday to Friday. So difficult.
But no, it's definitely something to look at for people listening if you haven't heard of that before, to look into it, because I've only recently learned that. I thought it was quite interesting. So think about this, Dawn. So you're a fly on the wall in an ambulance, right? Here we go. And you're the fly on the wall, and the ambulance crew are driving to a job. They're going to be first on scene to a lady in imminent labour, and you can see that they're bricking it. And I've been in that situation before. I've been driving, and my heart's been going at about 120, going, oh my god, what's it's going to be like when we're going to get there. And if you were that fly on the wall, you can tell that ambulance crew are bricking it. They've never delivered a baby before. What would you say to them? You've got maybe a couple of them. They're going to be on scene in about 3 minutes' time. What would you say to them to prepare them for the job? Either some tips top tips or some quick sort of tricks or anything just to prepare them for that job mentally?
Okay, so I've got 3 minutes. So I am going to say to them, even though they might feel like that they're more than capable of managing this job. I want to get them to feel less stressed. I'm here if they want me. And that applies not just to me, that applies to any senior clinician. You can ring the critical care desk for advice at any point. You're not on your own, is the point I definitely want to make. When you go in there, I want you to immediately put your hand on that woman's shoulder and tell her she's doing brilliantly and that she must follow whatever her body's telling her to do, because that's generally the answer. And then just get ready. Get your pack out, get your maternity pack out, get your resus area ready, and then you're prepared for whatever might happen next. If when you arrive she starts pushing, and there's a real difference between a woman who's contracting, I am not doing the noises today.
Oh no! Somebody asked me to get Dawn to do the noises. I've got to get you to do good. Yeah, they're like, get to do the noises. I'm like, okay, I'll ask. Like, you got to do the noises.
Oh God, are you going to make me?
Yeah, 100%.
Oh, no. Okay,
This is going to be the bit that like we get on the camera. It's going to go on the clips. Like,
you didn't tell me I was going to have to do this. Okay, we'll do it because it's important. So there's a real difference between a woman that is having a contraction and a woman who's pushing, and they sound like this. This is the contracting woman. Ooh, 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 and it'll reach like a crescendo, and then it'll climb back down again, and then she'll have a break, and then she'll probably have another one. This is the woman where you hope you've got your gloves on. It's more guttural, it's pushing. So if she's pushing, get your gloves on, get ready, because she's probably going to birth. You're going to be the person that's going to catch said new baby. If she's contracting, you might have time to perhaps think about leaving scene, getting her to hospital. But yeah, that's it really. You don't need to do an awful lot more other than have gloves on and be ready and be kind and tell her to do whatever her body's telling her to do.
That's awesome. So save that little snippet, and the next time you're yourself going to a maternity job, just play that.
Just
recording.
play Dawn's noises. Yeah, that's it. That's going in the trailer specifically. That is a TikTok
Dawn's
clip in the making, isn't it? Like
with Dawn's consent. Oh dear. So that pretty much ends our point in the podcast. Now we finished it a bit early because we had a hell of a lot of questions from people on Instagram, didn't we?
We did, yeah. So we had really good social interaction prior to this episode. We want to just quickly, actually, before we go on to the Instagram questions, throw a huge thank you out to our friend Jess, who runs the Student Midwife Studygram, which is how you can find her on Instagram. Jess provides lots of free educational content on her Instagram, as well as study materials that you can buy from her online shop. We've worked with Jess before. We think she's wonderful. We think all of her content's great. So be sure to give her a check out. And Jess, we really appreciate you giving us a shout out and working with us on advertising this podcast episode, to branch out to your wonderful midwifery colleagues who have asked us loads of questions to throw at Dawn, as have our ambulance colleagues.
Just to add though, that Instagram tag it's got a bit of underscores and stuff.
Oh, sorry, let me go back to the yeah, absolutely. So we are
it's student_midwife_studygram, and that's Jess's Instagram that Sam was just previously talking about. So, the first question that we had on Instagram was this. In active labour, how do we know if we've got time to drive very quickly to hospital, or whether the baby is coming, or when we have to wait on scene?
Okay, really difficult question. The bottom line is you don't. And it's really difficult because obviously midwives can do a vaginal examination and see how many centimetres she is, and that gives us a better idea of whether it may be coming now or in 10 minutes. To be honest, that's not an exact science either. So going back to the noises I just made, as pre-hospital clinicians, I would say that if her contractions are not very regular and she can talk through them, you've probably got time to go to hospital. If they're much closer together and she's struggling to speak during a contraction, I would want to have a little look to see, because obviously you can't do a vaginal examination, but you absolutely can visualise and see if you can see a head coming. So it's difficult, and I don't think anybody I think people expect me to be able to give them an answer that's definitive and saying, well, if this is happening, she's about to birth. If this is happening, she's not. But that it's not as straightforward as that. It's multifactorial, and labouring women, and particularly para ones, as we discussed earlier, could be chatting like I am right now, and 2 seconds later they're giving birth. Yeah. So I would love to be able to answer that more definitively, but I just...
No, that's good though, because at least then we can differentiate those noises, and I think that's something I've learned as well. Okay, so Tia has asked, shout out to Tia, the algorithm for neonate ALS is primarily ventilation. If we are unfortunately unsuccessful and we require to do CPR and oxygen, would we ever give adrenaline? And this is for the baby that's come out and the placenta is still in the womb and the baby is basically in cardiac arrest. Because J.R. Calc states that the adrenaline doses from birth. Tia also added that she appreciates that this is futile, but would we give the full ALS drugs? That's quite a long question, so happy to go over and break down that.
So if you, when I teach NLS to my colleagues, I always sort of say the point at which you need to do chest compressions, that's a really small percentage of babies, I think it's 5%. You need to be thinking about extrication, you need to be thinking about leaving scene, because that baby's had quite a hypoxic insult for you to need to do chest compressions. So the point that we're doing chest compressions, I'm going to start giving 100% oxygen as well, and I'm going to be thinking about leaving scene. Now, if you've got a senior clinician with you, you might think about giving adrenaline, yes, and yes, it is probably fairly futile, but yes, that's fine. I would be prioritising getting this child to definitive care and ventilating them well before I would be giving adrenaline. I'm not saying I wouldn't, but my prioritisation would be to get this baby to a neonatologist where possible.
And also, I think that all of the hands on deck, it'd be really difficult, because I mean, you're going to have to go intraosseous, and that's if you've got sort of 3 people doing the airway and the chest compressions in a moving ambulance,
Absolutely.
you're going to have, and this baby's going to be tiny. You're going to have someone else. It's just going to be like a really tight huddle of about 4 or 5 people all doing
really
one
difficult
thing. And for something that's kind of futile anyway, if you want to really get to grips on the airway and the ventilations and the chest compressions, sometimes it's probably more important to just go, let's focus on this.
And go. And I'm not a scoop and go person, because I know how that kills people, and that's bad. But I am somebody that's quite pragmatic, and I'm thinking, actually, the best place for this baby is with absolute specialists. And I wouldn't be hanging around. Because ultimately, if we're going to be doing IOs and everything else, that's going to prolong our on-scene time, and I don't want my on-scene time to be long for this baby. I want to get them to an expert. That's not me.
Yeah, that's it. And when we IO an adult, we can just pick a needle out. But I think with a baby, it's just going to be so much more. No one's probably IO'd a newborn before. And then, you know, you're going to go, what? And then we're going to be talking about, should we do this bit? What site should we do? And then it's just going to get, it's like you say, it's just going to delay on scene.
Delay that definitive care, isn't it?
Yeah, no, that's right. But yeah, Tia, I hope that answers your question. So, question number 3, there's 80 question. No, I'm joking, it's not really.
It is pass or fail.
So
you may be collecting your P45 at the end of the
So what top-up courses or CPD is available to paramedics looking to refresh maternity skills?
Okay, so is this generic, and I assume it's national, is it?
Yeah.
Okay, cool. Yeah. So each ambulance service does something different. So I know that NWAS and CCAM do pre-prompt maternity courses, and I think London do something similar, and I think the other ambulance services are doing their own variation of. So you might see advertised something that would be collective with the midwives in your local area. Chew your hand off, go on anything that you can to enrich that learning. My only caveat would be that actually a pre-prompt course is really good, because they've thought about the fact that you're pre-hospital clinicians. Some of the training that some of our colleagues have gone to in hospitals, I have to say I've hung my head in shame and been embarrassed. So things like the midwives will go in and treat the patient, and you guys will be told to wait outside, and at the salient moment they'll call you in with the stretcher. I mean, where's the learning in that? That's embarrassing, and I get really upset and quite protective of all my green colleagues when those sorts of training things go down. So try and find something that is recognised, so pre-prompt, I may have said that once already, or try and reach out to the leads for maternity within your service. You have all got a lead for maternity. They've joined me in the National Leads group. Okay. It's coming. We're getting better. We're trying to spread the word across all of the whole network. And lots of services now are getting midwives, so it will get better.
I think it's wonderful. I think it's the way forward, isn't it, to improve training? I mean, that links. I'm just going to link that question in with one that I've got here, because it mentions the whole prompt thing. So someone else asked, do you think prompt training should be mandatory for all student paramedics?
Yes.
Cool, there you go. How's that?
I think we need much more training in maternity, because of how often it can go wrong and all the various emergencies there are that can happen. I'd give you all a lot more training in it tomorrow, but it's not my decision. When I'm Prime Minister...
Yeah, there you go.
Well, I mean, vote Dawn.
Yeah, vote Dawn in the next,
Absolutely.
The next election's coming up, so yeah. So you've already touched on this question, to be honest, within our questions, but someone asked, any tips for communication in an obstetric emergency? How much do you say to mum? I know you said, that it's important, that's one of your top tips that you would say to prepare the ambulance when you were the fly on the wall. To the first thing, go in, put your hand on mum's shoulder and say, whatever you're doing, feeling it's the right thing, do what you think's best, and you're doing really well. Is there anything you'd like to add on that, or sum up, or anything like that?
Yeah, so in an emergency, my midwifery colleagues will have experienced this. In an emergency, women get really frightened, and particularly perhaps a hemorrhage, because the blood loss is fast. And I've had various patients say to me, or women, over my career, am I going to die? So you'll have heard this as well as pre-hospital clinicians. And it's a really horrible question, isn't it? Because you can't really answer it. Well, you don't know the answer for a start. But I have a sort of a staple answer to that now, where I always say, I've heard colleagues say, no, you're not going to die. That's the wrong answer. I would always say to somebody, you know what, everybody that needs to be here is here, and we're doing absolutely everything to help you right now. What I need you to do is X, Y, or Z. But you just stay there, okay? Bear with us. We're trying to help you, and if possible, try and do whatever our ask is. And in some of those maternity emergencies, it might be change position, for instance. But yeah, I would never say to somebody, and it's the same with somebody's baby, and they'll often say it to us again, won't they, as, oh my God, is he going to die? Again, staple answer, everybody that needs to be here is here, and we're doing everything we can for your little boy or your little girl, or whatever the case may be. Tricky. That's my only other tip, I would say.
I think that's a brilliant tip, though, because it's something that we get asked quite a lot, just generally anyway. And I think that when I first started out, I struggled with that question, and during COVID, that was because we had to cart people off by themselves, and the family would be like, are they going to be okay? And you would go, I don't know, is the honest answer. You'd have to call the hospital. Will they answer because they're so busy as well? It was difficult. But no, I think that's an awesome answer to a really difficult. Your
scenario is way worse. What you've just described. That's hideous. That's utterly hideous, isn't it? I'm so sorry. I can't answer that question, and I really empathise. I can't imagine. But I'm going to take the very best care that I can for your mother, sister, brother, whatever the case may be.
Yeah,
and I'm going to deliver them to some excellent clinicians.
So Sam, have you got another question on the list?
I have got questions, yeah. So this one is, I'm assuming, from a student midwife, based on, I had to ask what the 3-letter acronym here meant, but now I know. So even though the NMC have changed the criteria recently for spontaneous vaginal deliveries, SVDs they put, I was like, proud of myself for that. Do you still think 30 is unreasonable given the change in maternity now, as SVDs are more rare?
30 what?
SVDs.
30. Oh, I see. They have to do 30. Oh, I've got you. Okay, fine.
Qualify or be able to register. But they're saying that, do you think that's unreasonable given the change in births, maternity care now?
I think that's okay. I don't have an issue with it. It was 40 when I trained.
Oh wow, so it has dropped.
So it's dropped. The important thing, it's not about catching the baby, and of course when you first start your training as a midwife, it's all about how many babies have you delivered. Some of my midwifery colleagues are going to go, you don't deliver babies, pizzas are delivered. So I always say assist somebody with their birthing, but it's about that rich learning from looking after someone in labour, because actually anybody can catch a baby, anybody can do that. It's about learning how to recognise when things are going wrong. Different women's behaviours and what they might want and what they might not want. So earlier on when I said put your hand on a woman's shoulder, I'd say 90% of women will respond well to that. 10% of women won't want to be touched. Yeah. And so it's picking up on those clues and those non-verbal signs. Yeah. So actually that's the thing that we really need to learn. We need to understand women and their various behaviours and when they're transitioning from one stage of labour to the next. And you only get to learn that from caring for loads and loads of women in labour, and loads of women that will end up with different outcomes, different births. Some will have a Ventouse, some will have a forceps, some may end up going to theatre for an emergency caesarean, and some will have spontaneous vaginal deliveries. The most learning is from caring for women in labour. It's not from catching the baby at the end. That's easy. So I don't have too much of an issue with it, because I still think student midwives are going to get that rich learning from caring for women in labour, and that's probably why they've reduced it. I don't know the answer to that. I'm surmising.
No, you answered.
That's
awesome.
absolutely. I'll try and rephrase this one as best I can. So, if you could adapt the paramedic scope of practice, we'll take paramedics out of all the pre-hospital clinicians just because obviously they're the registered ones. Is there anything you would like to see added to their scope of practice in terms of like whether it be drugs or specific skills that say midwives have that paramedics don't, that might aid them pre-hospitally?
Yes, and I've already done some of these things. So when I joined, it became quite apparent quite quickly that none of you ever did internal manoeuvres, and it was a bit frowned upon, if I'm honest. You don't do that. Don't go there. Which I think is incredibly disabling, because we're sending you into somebody that might be an hour away from hospital, but we're basically tying your hands behind your back and saying, here you go, watch that in a stew, but you can't do anything about it. That's wrong, right? So yes, I added into the scope of practice within CCAM that you could perform internal manoeuvres so that you could get women and babies out of difficulty. And I've taught many of you how to perform those internal manoeuvres. So the caveat is always that you can perform these manoeuvres if you've had the training.
Yeah.
Our critical care colleagues have had lots of training in this, and they will always try and run to these jobs with you and assist you so that they're there. We can't always guarantee that, so it's important that all of you have the skills. So that's one thing that I have hopefully changed for the better. What else would I like to do? So there's one other thing that would be useful, but I have to be really careful because I can't make you into midwives. And you're not midwives.
Yeah.
So we have to know where to draw the line. But just sometimes when women are bleeding and they've still got their placenta in situ, I really want you to be able to get that placenta out, because if you get that placenta out, the uterus will contract and hopefully the bleeding will stop.
Yeah.
And I would have to talk you through it on the phone. That's okay to a point. But sometimes I think, particularly in more remote geographies, not necessarily London, because you've got a hospital close by pretty much everywhere, but in some of the more remote geographies, I think that's going to be an essential skill that people will need over time.
Yeah, that's that would be pretty mad. So would that, in terms of like getting the placenta out, would there be drugs added to the gel calc, or would it be literally a
So we already give the drugs. Yeah. So at the moment in our service, we give something called a uterotonic to make the uterus contract. But we only give it for hemorrhage. But ultimately, if the placenta is still inside, there's a limit to how well that uterus can contract, because it's got a big lump of placenta in it, and I need that out for it to work really efficiently. So they kind of go hand in glove, if you like. So if I could teach you how to do that during a hemorrhage to help the placenta to be birthed, then the drug would work more efficiently. So you've already got the drug, you now need the skill to go with.
Yeah. Oh.
And where you've done the first part of what we've implemented for your trust, have other trusts that have got these consultant midwives, have they implemented that for their trust as well? Is it becoming a national?
Yes. And there's a piece of work. So we've just rewritten the JR Calc hemorrhage guideline, and we looked at all of the different services and what they offer. It's challenging because the drug that we would like to give, Sintometrin, needs to be stored in a fridge. And if it's not stored in a fridge, you have to dispose of it quite regularly. And that's obviously a cost pressure. So we give it to our more senior clinicians. But there's another drug called misoprostol. By the way, nobody can ever say it, so we call it miso, which is also a uterotonic. And so that's tablets which can be given sublingually or PR. So all of our paramedic colleagues carry that within the ambulance trust that I work. So you can use either, or you can use them both. And obviously you've got TXA at your disposal as well.
Oh, there you go.
There you go. Awesome. I think we have one last question to end on, and we've saved this one for last. I quite like it. I think it's quite a nice sort of thing that we can end on. So someone's asked, can you tell us about a case that reminded you of why you're doing this job?
Yeah, I can. Got to try not to cry, you buggers. Okay, so yes, it was last year, and some of our colleagues had gone to a breech birth, which wasn't planned to be had at home. Poor mum had been caught somewhat short, and they couldn't basically get the head out. So the body had delivered, but they couldn't get the head out. So critical care desk have got all the algorithms on how to manage all of the maternity emergency so that they can assist our colleagues over the phone. But on this particular day, the critical care paramedic rang me. It was a Saturday morning, and she said, can I conference you into the crew? Because we're struggling to help this baby be born. And I said, yes, that's absolutely fine. And it was interesting because where we're sat right now, in my kitchen, is where I took the phone call. and my parents were sat on that sofa over there.
No way.
And so it was really difficult. So they were listening, and my poor dad's quite an emotional man. And so I started to talk to the crew, who were just amazing, absolutely amazing. And we talked through lots of different position changes. And eventually we got Mum to do a squat. She was basically holding on to either colleague, either side. And she did like a massive lunge down. And they got her to continually push. And eventually that was what birthed the baby. So we got the baby out, which took about 7 or 8 minutes, which is quite a long time in the world of maternity. And plus add on to that the amount of time before I was conferenced into the call that they'd been trying. So collectively, they literally went through every single thing that we'd tried. And it was so slick, I can't tell you. They got the baby out, and then we did 12 minutes of NLS. And when the baby came out, it was white, it was toneless, had no heart rate, 0 heart rate, and it wasn't breathing, obviously. So this was your worst case scenario. This baby was a rag doll. And they did everything. We went through the NLS algorithm from start to finish. By the time I ended the call, in total it was 16 minutes later, the baby had a heart rate of 140, was doing really well. Wow. And this baby went to hospital. They conveyed to hospital. HEMS had lifted for this, and they were coming down to assist. But I think by the time HEMS had landed, they were already on their way to hospital. And the baby went home a week later. So that sort of job is when you think, oh, that was really good. You know, as a team, we recovered a horrendous situation which could have gone really horribly wrong. And we resuscitated the baby, and you know, that was a family that was saved. It was in Sheppey. So it was in the, you know, it was a long run time. It was in the middle of nowhere. So, and that's the thing, isn't it? You guys go out to some really remote places, and we know that we haven't got very long to get out a neurologically intact baby. And so that's why you need the skills. You need to know how to perform these internal skills to get these babies out, and hopefully, you know, have a positive outcome. So that reminded me of why I do this job.
Oh,
that's awesome.
That's a lovely story.
I think that you had the added pressure of having your family basically watch you work.
Well, they all went silent, and at the end my dad burst into tears. I know, and he said, "Is that baby going to be okay?" And at that point I didn't know, because obviously I left them at the point of saying, "Are you okay? Have you got this?" And they said, "Yeah, we know what to do now, we're going." And I said, "I'll leave you with it, you know where I am if you want me." And I hung up, and that's it then for me. And then I just have to wait for the crew, and some do and some don't. I then wait for the crew to call me afterwards, after they've handed over, normally for a debrief, and wait for them to say, "Oh, thank goodness for that, let's talk it through." So it was really nice to hear that the baby went home a week later. I did text my dad.
It's like an experience for everyone, isn't it? Like that was in the room. And then I suppose also, like, another thing that I definitely used to do was think or have this idea in my head that specialists in their field were like not human and without emotions, and that they probably don't really care what happened to this baby afterwards or that patient. And so you know, you don't really think about that, but then actually everyone is human, and there are like members of the public literally look at paramedics and go, "You are heroes," and I'm like, I'm not a hero. I'm just a normal guy that comes to work.
No,
but
that's cringe.
But you know, but it's true though, isn't it?
And people do.
And that's the way everyone has their own level of what a hero is, and some of the, especially the critical care paramedics, or like you got a midwife that is helping you through probably the worst job of your career. You know, you're going to look at them like you're going to go, "You're not human. You are a hero."
Oh yeah,
there
is
something.
Oh no, nurses and midwives are angels.
Yeah.
There you go.
You're heroes. Angels.
Nothing grates me more than someone calling me an angel, because I just think professionally that's so disrespectful. They don't mean it to be. They think it's a real compliment, but I think no, I'm not an angel. I've got a skill set.
But no, this has been an amazing chat, and I've definitely learned something.
Oh, absolutely, yeah, it's been very insightful. Dawn, we are so grateful for your time. Thank you very much for agreeing to come on.
It's been my absolute pleasure.
Yeah, we'll hopefully get you back again in the future.
And yeah, no, thanks so much for listening. And like we say every single time, Bullhorns and Sirens is on Instagram and Facebook, so you can follow them. And we also have Pocket Clinician.
We do indeed, yeah. You can follow us at Pocket Clinician for more educational content, more aimed at sort of student paramedics and pre-hospital clinicians. But student midwives, student nurses, please feel free to check out as well. And then stay tuned with us. Our next episode following this one, we are talking with Katie Pavoni, who is the head of paramedic science for a London university. We are recording with her next, and we're very much looking forward to that. Keep your questions coming in for her. We hope you've enjoyed this, and give us a follow, like and share.
Yeah, thanks so much for listening. Thanks so much, Dawn, as well. You've been amazing. See you later.